to be a demonstration on the blood transfusion, and I'm going to demonstrate that for you today. First of all, what you want to do is check your doctor's order and make sure that you do have an order for a blood product, and in this case I do. Doctor has written infuse 1 unit of packed RBCs, and I'm going to go ahead, check my order, it's there in the chart. I'm going to check and make sure that there's a type of cross match on the chart, that it's less than 72 hours old. At that point, I'm also going to check and make sure that the patient has signed a consent form for the transfusion, and they have. I have that in my hand. And I'm going to go ahead and kind of wonder why this patient's getting this blood, this unit of packed RBC, so I can go back and check the CBC. Maybe their H&H is low and they're having symptoms. They're pale, short of breath, and their oxygen saturation isn't the best. And doctor wants them to have a unit of blood. So I've done all that and verified everything. At this point, I'm going to go into the patient's room, wash my hands, and I'm going to go ahead and check 2 forms of ID and make sure it's the correct patient, and it is. Are you my type? Date of birth 1956. And are you my type? Hi, I'm Mrs. Harto, and I'm going to transfuse a unit of blood today. Your doctor has ordered for you. And at this point, the patient might ask you questions of why they're getting the unit of blood, so you want to go ahead and explain what's going on, why it's been ordered for them, etc. I also want to ask him, do you have any allergies? And in this case, we're going to say that he's told me that he does not have any allergies, but if a patient does have a history of a lot of allergies, you might be a little more suspicious that they might have a reaction to the transfusion. I also would like to ask him if he's ever had a transfusion before, and if he has he ever had a reaction to a transfusion before? So them are all important pieces of information to collect. At this point, I'm going to go ahead, I'm going to put gloves on and start my assessment. I'm going to take vital signs. I'm going to make sure temperature is within normal range before I even hang the normal saline. And I'm going to go ahead and check the patient's IV site. And they do have an IV saline port in their left anapube area. It's a number 20 gauge, and we can use a number 20 or a number 18 gauge catheter, so we're good there. The next thing I want to do is I brought a flush with me, and we need to flush it and make sure it's patent. So I'm going to go ahead, take my alcohol wipe the access port, take my cap off the flush, go ahead and connect, aspirate for blood, and just instill a couple milliliters of normal saline. Make sure it's patent and relock it. Okay. So his IV saline port is good to go. It's patent and it's ready to be used. At this point, I want to take my stethoscope and I want to do a pulmonary assessment. Make sure I get a good baseline lung sounds. And currently his lungs are clear and we should be ready to go. So I'm going to go ahead and I'm going to collect the materials that I'm going to need. Normal saline, and I'm going to need a blood administration set. The blood administration set might be a little different. It differs in all different facilities, depending on what kind of IV pumps the facility uses and whatnot also. And because we're only transfusing 1 unit of packed RBCs, what I'm going to do is probably use a 250 milliliter bag of normal saline. I have my blood tubing, and there are 3 actual roller clamps. And the next thing you should do after you open your blood administration set is to close all your roller clamps, okay? And I'm going to go ahead, spike my normal saline bag, okay, with one side of the Y arm of my blood administration set. Okay. Go ahead, pull this off. Okay, in it goes. All right. IV pole because it's easier to let it hang there than me try to finagle 600 things in my hands. And what I'm going to do is I'm going to go ahead and prime this administration set with the normal saline. So I'm going to open the Y port, the Y clamp on the Y side of the normal saline that I spiked. I'm going to loosen the end of my IV tubing to make sure that it can breathe. Okay, so while I prime it, and I'm going to go ahead, first of all, and I'm going to fill the chamber in my blood administration set. I'm going to fill it so the normal saline comes just above the inline filter in that drip chamber. And that's because I don't want, once I spike the blood bag with the other Y port of my Y arm of this blood set, I don't want the top of this inline filter to be exposed, because then it means that when my blood starts, my red blood cells are going to hit the top of that and it's hard and they're going to break. I don't want that. So that's, normal saline is above the inline filter, and I'm going to take my roller clamp from down below and I'm going to go ahead, open it up, and I'm going to go ahead and prime the tubing. Okay? At this point, I've still kept the end of my sterile cap sterile, and I've already flushed the IV site, so I can go ahead and just hook this to the IV site. I might have to wipe the excess cord again with the alcohol prep. Okay, unlock the Y side, the actual slide clamp of the saline lock. And I'm going to start this running at KVO rate. So that's about 25 milliliters an hour. Now, if I had an IV pump, I could just put it on the program 25 milliliters on the IV pump, but I don't. This is gravity, but I have 10-drop tubing. So if I use my magic number, which in this case is going to be 6, then I could take 6 and put it into 25, and I'm going to get 4 drops a minute, approximately 4 to 5 drops per minute, which means that's about 1 drop every 15 seconds, okay? And that's pretty slow if you think about it, so that can be a little difficult to do also. But what I want to do is, this clamp I want to leave alone. I'm going to regulate the flow with the lower roller clamp on the main tubing. I'm going to put my watch just behind the drip chamber so I can see the drips, and I'm going to start that going just at a very, very slow rate, just enough to keep the vein open. Okay. Alrighty. So that's running at KVO rate. I've been notified that the blood is ready in the blood bank, so I'm going to take my requisition form and I'm going to go to the blood lab and I'm going to pick up my unit of blood. Hi, this is part 2 of blood administration, and I just got back from the blood bank with my unit of packed RBCs. I just want to remind you also, don't forget that you must do patient teaching regarding a unit of blood. Explain to the patient signs and symptoms that they need to be aware of in case they experience them, and then they need to call their nurse ASAP. Some hospitals do have policies, little booklets, like teaching booklets that you hand to patients that tell them about the transfusion that they're receiving, about any symptoms that they need to be aware of and whatnot. So that's also very good if you can get a hold of one of those. I am back, and I have just gotten back to the unit with my unit of packed RBCs, and I am going to ask another licensed professional to come in and double check this information with me because it's important, and it's important that we do this at the patient's bedside. So I have a unit of packed RBCs for RU my type. ID number 52256.
52256.
And the blood type is AB, RH positive,
AB positive,
and the donor unit number is 0016157,
0016157,
and the blood band number is ABC987.
ABC 987,
Okay, and it expires 10/15/10.
10/15/10 expiration date.
Okay, and then Ms. Mack, she's going to go ahead and verify that she's checked that information with me. She's checked everything. Thank you very much. And we do indeed have the right unit of blood for the right patient. And in real life, guys, you're going to have actually a little requisition form coming off the blood bag itself that has all the same information. So as you noticed, when Ms. Mack and I were checking this and verifying this unit of blood and the information that we needed to check, that we were looking at the requisition that's coming off the blood bag, we're looking at the patient's arm band, plus the blood band, should they have one. Not every patient's going to have a blood band or a blood ID number. And we were looking at the requisition form. Okay, so we're matching all that information. Now I'm going to go ahead and just gently rotate the blood bag, mix up the preservative, mix up the cells a little bit. I don't want to shake it, just gently rotate it. But it's also at this time that I can actually assess the blood, make sure it's not brown, bubbly, leaking, anything that might indicate that it's there's bacteria in there. Okay, and at this point also, I'm going to take the patient's vital signs just before I start this transfusion, just to make sure. Now the vital signs were fine before I went to get the blood, but it's essential that you put the pre-transfusion vital signs on this requisition form. So I've taken vital signs are fine, temperature's fine. I'm going to go ahead and before I actually spike the blood bag on this Y port, I'm going to actually prime this Y port. And I'm just going to prime it by loosening the cap and opening the clamp on this Y arm. And just by gravity, the normal saline should prime that little tube in, which it did, and it is, okay? And there, that's all primed. Now I'm going to go ahead, take my spike out of my blood bag. I'm going to go ahead and spike it with the other Y arm. I'm going to close the normal saline on the clamp on the normal saline. Go ahead and hang my unit of blood. Okay. And I'm going to open up the clamp on the unit of blood. I got that, and it's running at 75 milliliters an hour for the first 15 minutes. I've documented my vital signs. I'm going to stay in the room with the patient. I'm going to observe them for any adverse reactions. This is where I can grab the patient's chart. I can start documenting on the bedside chart. I hung a unit of packed RBCs. I could document that the vital signs and what they were pre-transfusion, that they had a number 20 angiocath in their left antipube area, patent without complications, and that their lung sounds are clear, so I can kind of document donor unit number was and patient tolerated procedure well currently. We'll continue to monitor and follow as per hospital policy. So for time's sake here, we're going to say that 15 minutes is up, and I'm going to go ahead, I'm going to retake vital signs on the patient. And vital signs are fine. I'm going to document them on the requisition form. And I'm going to proceed to follow the hospital policy, because each policy is different at each hospital. At this point, because it's best if we can get the blood in at a rate that's as fast as the patient can tolerate, I'm going to try to get this unit of blood infused, over a couple of hours. So now that I see that there was no reaction and that vital signs are fine and lung sounds are fine, I'm going to go ahead and I'm going to bump the rate up to 125 milliliters an hour. Okay, so I'm going to go ahead and do that. And it should go in, so that's going to get that in well within our time frame of a whole 4 hours time limit. And I'm just gonna monitor the patient as per hospital policy. And when the blood is done, I'm gonna then close the clamp, the right side of my blood unit. I'm gonna open the clamp of the saline, the right side of that's running to my saline, and I want to infuse it. And you can infuse it at a rate that perhaps the blood was running at, 100 cc's an hour, and infuse about 50 cc's, which would put about 50 cc's of normal saline in over a half an hour, just enough to clear that line, because there's a lot of residual blood cells in that line even after the transfusion bag is empty. So we're gonna go ahead and flush the line, and we're gonna make sure that you take vital signs post-transfusion and document them on the flow sheet. And we need to do that before we actually start flushing the line. When it's all done and it's all flushed, what we could do is close our clamps, unhook it from the patient, put all of these, the blood tubing, the blood bag, the normal saline bag, all in a red biohazard bag, take it to the dirty utility room and discard it. Go ahead and flush the saline lock again, make that so it's patent, there's no blood residue in that, and lock it off, and continue to monitor the patient and continue to monitor